Hi, this is Andrew Phillips, the editor-in-chief of EM Coach, the only artificial intelligence-driven medical education platform out there, welcoming you to another edition of our Question for EP Monthly. So I'm actually going to talk a little on this one about what's not in the explanation for the question. If you haven't read it already, please do. We do spoiler alerts with this. It's a gentleman who comes in with CHF. We see this quite often, and it talks about what you're going to be treating with, and it goes into nitroglycerin and the high doses and how even 2,000 micrograms can be helpful. One of the points that it brings up is using non-invasive positive pressure ventilation. And I want to talk a little bit about that strategy. This question doesn't dive as deeply into that, but it's a very common mistake that I see, that when people have a CHF exacerbation, this is an issue with a VQ mismatch. It's not a ventilation issue, it's an oxygenation issue. And so to that end, the non-invasive positive pressure ventilation, you should be getting theoretically more benefit out of a CPAP than a BiPAP setting. Let me explain why. One of the reasons that non-invasive positive pressure ventilation is helpful in your CHF patients is, to some degree, stenting open those alveoli. But as you increase that intrathoracic pressure with a CPAP or PEEP, same thing, right? You're also reducing the preload. By blowing up the pressure in the chest, there's less blood coming up into that RV and then, or RA, up into the RV and then around to the lungs, right? So you're reducing the amount of fluid that you're shoving into the lungs, and then you're able to get more out as that LV is able to push that blood because less is coming in, with the heart having difficulty pumping, right, with the decreased contractility, or even with diastolic dysfunction. So if you're using a CPAP setting, you can actually crank that PEEP fairly high. Now, the pressure at which the gastroesophageal junction can hold is approximately 20 to 22 centimeters of water. So I tend to stop at about 18. There's no great guideline or strong amount of evidence other than the physiology studies. And you don't want to go beyond that 20-22 because then you're going to be blowing up, have a high risk of blowing up the stomach. So if you have CPAP, you can increase that all the way up to whatever you're comfortable with, 15, 18, etc. If you're using BiPAP, then you have that lower number and then a higher number. And by virtue of having that higher number, it doesn't allow you to take your lower number as high. And so during that time that you're delivering a breath, that means that preload is not being reduced quite as much because you're having to get a delta. So when is a BiPAP setting with a large delta helpful? That's more for like your COPD patients who are retaining CO2 and have to blow that off. So you want more ventilation. And so you're looking at two different major functions of your non-invasive positive pressure ventilation. When you have a CHF patient, my recommendation, and this is not necessarily guideline based, this is theoretical, and by practice I find more helpful, to start with a CPAP setting and see how they do with that. You can crank that up. Try 10, 12, 15, even 18 centimeters of water of your CPAP. And it's helpful because it reduces that preload and that helps stent open those alveoli. And without a doubt, multiple studies have shown has reduced the risk, or the need rather, of having to intubate the patient. So there you go, CHF. Read the question for a little more information about the nitroglycerin infusion. And there's a little tip: try CPAP first on your CHF patients and BiPAP first for your COPDers. This is Andrew Phillips from EM Coach. Thank you for watching.